I've talked on two main topics that you probably remember: our opioid misuse strategy, misuse and prevention strategy, as well as our drug Medi-Cal update. So I'm not going to go in too much depth on those two topics, but what I'm going to try to do is highlight how that fits in the sphere of medication-assisted treatment. So you can sort of put it together. Sometimes when you hear one thing and you hear new information, you want to put it together. And that's really, to Marla's credit, I think, really why we're here today. Because this is a community-wide effort to educate and to fight a lot of stigma and make sure that clients are getting access to the best treatment they can get access to. I'm always so impressed when I hear Dr. Esposito speak, and I want to highlight something that's really important for you to hear today. The same thing that it might feel new to you to hear the information is the same thing that's happening within the medical community. There is not broad acceptance in some sections of the medical community, substance use disorder providers, certain folks working in hospitals. This is something that we all need to be change agents for. The science is clear. There is actually no dispute about many of these topics in terms of the effectiveness of medicine, but the broad understanding with the medical community, there are many, many doctors who haven't received this information. Years ago, this wasn't part of medical training. Most of our new grads coming up, they understand this. It's native to them. It's confusing to them why it's not broadly accepted, but we have folks that are in practice today across healthcare systems that might not have been exposed to this information. So if you're in a situation where you have a loved one, you have a client you're working with, and you hear different information, it's really important that you advocate and you make sure that you're getting somebody to a healthcare situation or to treatment that is offering medication-assisted treatment when you're talking about substance use disorders. So this is the need in our community. I mentioned it before. This slide hasn't been updated since the last time we went to the Board of Supervisors. However, I'll just highlight that in 2018 from your report card, it was 92 deaths that involved fentanyl in our community. But the need overall is not going down for substance use disorders across our community. One of the things I like to highlight is what is the role of the county when it comes to treatment of substance use disorders broadly, prevention for substance use disorders broadly. The county is a contractor. Our entire substance use disorder network has a relationship with contractors who are providing these services. We have some organizational providers who have some substance use treatment embedded or infused, screening, referral, but they're not a direct provider of substance use disorder services. Our contract network is. We'll get more into detail with that when we talk about the drug Medi-Cal. We do have some direct service. Our primary direct service that you might be familiar with, San Diego County Psychiatric Hospital. We have 3 mental health providers that do direct service. We're a public health entity. That's one of the reasons these sort of settings are so important, because even if we're not talking about service to folks that the county has direct oversight, folks with Medi-Cal or who are underserved broadly, we are very invested in making sure that all people get adequate services and that the right services are available to folks regardless of whether or not they would be in the county's realm of providing this service. And then we're a health plan. We are, for folks with Medi-Cal or underserved, in general, there's a cutoff income level for folks who would qualify for our services. We're their health plan. So if somebody has a substance use disorder, just like you would pick up the phone and ask, where's my network for care? For somebody with Medi-Cal, when it comes to substance use disorder, we're actually the health plan, as well as for specialty mental health. We're the health plan. And I spent about, I think it was 20 minutes or so here and with the Prescription Drug Abuse Task Force talking about our opioid misuse prevention strategy. Medication-assisted treatment fits in up here at tertiary prevention, okay? Up here, this is where we're looking at prevention of death. Okay? When we talk about medication-assisted treatment, a lot of people say, why are you guys so focused on this? Don't you want to stop the illness from starting? Well, of course, we want to stop the illness from starting. We take great effort across our community to stop illness before it starts. We have many efforts. You guys could teach that to me. All of our primary prevention efforts to stop the illness before it starts. But when people get ill, it doesn't mean we don't continue to prevent further harms. Medication-assisted treatment does that. When you offer medication-assisted treatment, it prevents death. That's called tertiary prevention. It is prevention. And it's a concept that most people don't fully understand. They think of prevention only as primary prevention. But all along the way with illness, you can prevent further harm. So it's really important to know that offering medication-assisted treatment is prevention. And then also another form of tertiary prevention, which Dr. Esposito highlighted, is making sure that folks are aware in our community, either co-prescribed Narcan, naloxone, or that we make sure that all folks in the community are carrying it, people have loved ones, make sure they have it accessible, know how to use it, and make sure when it's deployed that people are being connected to treatment. And here's our drug Medi-Cal update that I gave at this meeting also. So this is the county's system of care. So for folks who have Medi-Cal or in certain income levels, if they come to our services in July 2018, we had a huge overhaul of our substance use disorder network. And I think it's a major opportunity to integrate broadly substance use disorders with the healthcare system. Previous to the drug Medi-Cal update, our opioid treatment providers were not part of the county system. With the drug Medi-Cal update, they came into our system. They were very well positioned to just fold right in. Their healthcare operations were very seamless. I think it went very, very well bringing them into the system. And now what I think is really powerful is they have now a better relationship with community providers, so that the expectation is if they're serving somebody, that they are working together with other networks. It's historically been very difficult for somebody who is on a medicine to get residential level of care. If they require that. Sometimes people require high levels of care, and historically they were told that they couldn't go to a residential program if they were taking a specific medicine, or that they must stop that medicine before going into residential level of care. It's very, very unfortunate, especially when you need that sort of residential level of care. The illness is very advanced. That is absolutely the last place you would want somebody to stop the medicine. Okay? So with the opioid treatment providers coming into the network, it is the expectation that all of our providers screen people from the get-go. If somebody has an opioid use disorder, if you don't offer it at your program, you need to refer and link and make sure that somebody gets access to life-saving medicine. I just wanted to just highlight that one of the reasons that I hope my presence here will be helpful is when our other providers ask questions about, what's covered, what's not, how does this fit together, in our role as a sort of public health entity, we can help folks navigate what fits where and how do we work together.